Clear.
Okay, so welcome everybody. We are live now on YouTube and Facebook. I hope everything will get started up here in a second.
All right.
Everything is starting to pop up. Grab this link over here that I hope is now on this page. And I guess we have to refresh, right? And I will switch over to you, Madam. And you are live.
Awesome. Thanks, Boyd. Welcome, everybody. Tonight we are ready for another student support call. Tonight's is all about auditing and practice management. I will admit I threw a little bit of E&M in here because it seemed like a good thing to go along with the auditing side of things. We've got a ton of topics to go through. If you've got questions tonight, if you're logged into the webinar, if you're one of the students that's logged in through the student support area, be sure to feel free to put your questions in the chat area, and I'll try to answer them as I can. And if you're watching on Facebook or YouTube, please be sure to put your questions in the chat as well. Lorraine's along to help kind of manage that for me and help make sure that we answer as many of the questions as we can. That being said, we will go ahead and get started with tonight's student support call, Auditing and Practice Management for January 31st, 2017. We're going to start with auditing and compliance. We'll work from auditing and compliance into evaluation and management, and then we'll kind of wrap up with the practice management side of things. I'm going to start with a question that I received from an auditing and compliance perspective asking about addendums to the medical record. Specifically, the question received said, regarding documentation, is there any portion of the review of systems or the exam that the physician is allowed to go back and add an addendum after the patient is gone from the office? We have an issue with downcoding, and the physician thinks that he should be able to go back and make an addendum. Well, you get into a bit of a sticky wicket when we start talking about addendums. The provider is allowed to make any kind of amendment, correction, addenda, late entry that is needed to be made into the medical record. If they do that, if they go back and they make an addendum or a correction or a late entry of some sort, they have to clearly indicate what the change is that they're making, the date, their identification, right, the author who's making that change, and we've got to leave the original content intact. That means if we're on a paper record, it's a single strike through so it can still be read. If it's in an electronic medical record, there's got to be a log showing what was kind of struck out, and it can't just be deleted and disappear off of that document. Medicare gives us a nice coverage article to kind of talk about making these corrections. It's an MLN Matters. Specifically, the MLN Matters number is S as in Sam, E as in Echo, 1237. And it's talking about the importance of preparing and maintaining a legal and legible medical record. If we scroll down to the second page, under the key points, they talk about amendments, corrections, and delayed entries, and that they can be made and what the key pieces are that have to be documented, right? Clearly and permanently identify amendments, corrections, or addenda, clearly indicate the date and the author of any amendments, corrections, or addenda, and clearly identify all original content. It cannot be deleted. But the question was more along the lines, from the sounds of it to me, that the provider wanted to change things after his documentation was reviewed and a code was recommended, right? They thought, oh, well, I didn't document enough. I should really be getting to a higher level of service, so I want to go back and fix some of the things that I really did, but I failed to document. That's where we hit a problem. Making changes after an audit or a prospective review where you've got somebody reviewing the charges before they go out the door, those can get you into trouble from a compliance perspective. And you really should not be making changes to the level of service after a review if it's simply that they didn't like the level of service that was reported, or they said, oh, well, it shouldn't have been that low, it should have been higher because I forgot to document something. Well, you get yourself into a little bit of trouble there, because now if an auditor, an outside auditor, were to come in and look, they can absolutely figure out that, oh, this was already reviewed And once it was reviewed, then the provider made some changes. And then you get into that, well, was the change really necessary? Those types of things. I included another link down here, down here at the bottom for Noridian Medicare. And the reason I did that is Noridian is one of the few that gives us some pretty clear guidance on making amendments to a medical record. This link takes us, Noridian is one of the Medicare administrative contractors. Specifically, they govern Jurisdiction E, which covers California, Hawaii, Nevada, American Samoa, Guam, and the Northern Mariana Islands. So you'll notice underneath here, remember, if you're looking for these same rules, they may not apply depending on who your MAC is. So reach out to your MAC, search their website, see if they have something similar. I know CGS Medicare has something similar on their website, but not all of the Medicare administrative contractors are quite as clear as Noridian is on this particular point. Basically, they give us some clear-cut guidelines for making amendments to a medical record. They go through, right, what's important to make sure that is included in the medical record. And when we get down to amendments, they talk specifically about late entries, addendums, and corrections. And the addendum is used to provide information that was not available at the time of the original entry. Well, that's really not what this doc is doing. This doctor is making a late entry. Right? A late entry supplies additional information that was omitted from the original entry. A late entry can be added, but this is the area that I would want to talk to my physicians about, because when we're looking down here, they clearly identify that we want to avoid falsifying documentation or even the appearance of falsifying documentation. And this is kind of when we're talking about adding to existing documentation, except for late entries, addendums, and corrections. Those are all acceptable, but when an audit prompts a late entry, that's when we can get ourselves into looking a little suspicious, right? They talk right down here about corrections to the medical record legally amended prior to claim submission and or medical record review will be considered in determining the validity of services billed. If these changes appear in the record following payment determination based on medical review, only the original record will be reviewed in determining payment of services billed to Medicare. So that's right there is where they're telling you if you get an initial determination from us and you don't like it and you change something in the documentation to support a higher level of service, we're not going to look at what you changed. We're not giving you credit for that after we've already made our initial determination. So that's really where you want to be careful in how many late entries, and you don't want your provider getting into the habit of that because it just creates other issues. All right. Let's see. Next question. This was an easy one for me. The question was related to someone who had their CPC thinking about sitting for the CPMA exam. And the question says, is it a far leap from the CPC to the CPMA? Well, I don't know how far of a leap it is, but it depends really on what your background is. The CPC and the CPMA are two very distinctly different exams. They test on different subject matter. The CPC is completely coding based, right? It tests us on CPT, ICD-10-CM, as well as HCPCS. And really the emphasis is on using our books, knowing the guidelines, being able to follow the parentheticals and the rules that are given in the coding manuals. There's very little emphasis put on billing regulations, documentation regulations, all of those different pieces. The CPMA exam is significantly different. Only about a third of the CPMA exam is even on coding related areas. The vast majority of that exam covers all of the other things that you have to know as an auditor, including audit scope and statistical sampling and documentation guidelines, compliance rules, payer guidelines versus coding guidelines, all of these different things that factor in. So yes, you do have to know the coding. And when it comes to coding, you really have to know more than you had to know for the CPC exam. Because, for example, if they start asking you about an evaluation and management service, you need to know how to level an evaluation and management service. not like the CPC exam where the level of history, exam, and medical decision making is given to you. In the CPMA, they give you the actual pieces, right? Here's the HPI, here's the review of systems, here's the past family social history. You figure out the level of history, and you have to know both the 95 and 97 guidelines. That being said, another common misconception many people have is that the CPMA only tests on evaluation and management services, or that if I'm really strong at evaluation and management, I shouldn't have any trouble with the CPMA. That is not true. And that's because the CPMA is a true auditing credential. It's not just evaluation and management services that can be and will be audited on that exam. It runs the gamut. It could be anything in that CPT or HCPCS book from a service perspective, as well as any diagnosis codes from an ICD-10-CM perspective. Typically, the areas that are audited on the CPMA exam, or the coding areas that are included, are oftentimes those that are sort of hot-button issues on the OIG work plan from year to year. I know back when I took it back in 2012, two of the big hot-button items were physical therapy and chemotherapy, and there were a ton of questions on PT and chemo back then, because those were kind of the hot-button areas. So you've got to be familiar with a lot more than just how to use your code books or even evaluation and management services. Is it a big leap? It really depends on what you do day to day. When I sat for the CPMA exam, it wasn't a big leap for me because I'd already been working as an auditor for 4 or 5 years by the time I decided to go sit for that particular exam. So you've got to keep a lot of that in mind, a lot of your background and the different skills that you have at that point in time. All right, the next question. Oh, I like this one. This was another auditing and compliance question, and it was talking about red flags. When is a provider kind of going to be red flagging themselves by doing certain things? This question says, if a CRNP, that's a certified registered nurse practitioner, sees a patient on a regular basis, maybe 2 or 3 times a month, for a problem-focused office visit in the outpatient setting, right, outpatient office visit, does it cause a red flag to CMS? The nurse practitioner is managing a chronic condition. Well, the answer is it depends. More than likely, no. It's not going to generate a red flag. It's not going to create an issue because there may be a reason that that patient needs to be seen a couple times a month for their particular chronic condition. The situations where it may cause a red flag: 1, if you're billing incident 2. Got to make sure that you're meeting those incident 2 requirements. And by that I mean it cannot be a new problem to the nurse practitioner. They cannot change the treatment plan. The treatment plan has to have been established by the physician, and all of those different incident 2 rules. The other situation where it may cause a red flag, and it's not necessarily going to cause an out-and-out red flag to the carrier, but the carriers, all carriers, not just Medicare, but they tend to start doing these provider comparison reports. That's a big thing right now. I don't know if anybody's received a provider comparison report in the mail. If you do at the office, don't ignore it. A provider comparison basically takes your provider and shows them where their coding profile falls in comparison to other providers of the same specialty in the same geographic region. Right? Your family practitioner may compare them to other family practitioners in the same region, same area. And if their coding profile is significantly different than that of their peers, for example, this nurse practitioner, her peers may be, kind of a standardized bell curve where the vast majority of their services are in a 99213 to 99214 world, and she's got more 99212s than anything. That could absolutely, and I shouldn't say she, that's just where my mind goes, he or she, that may flag them, that they're consistently reporting a lower level of service than their peers. Well, it may be justified depending on the types of services and the types of conditions that they are treating. So if you get a comparison report and your provider is listed as being kind of outside of the norm, or they're concerned about your provider's profile, do not ignore that letter. Respond to that letter, because that letter is basically kind of a warning sign saying, hey, if something doesn't change or you don't tell us why your provider's out of the norm, we're going to do a full-fledged audit on your provider. And those are becoming very common right now, something we're seeing more and more of. So be sure that you don't ignore those. All right, now we're going to move into some of our evaluation and management questions. Before I do that, I want to stop and take a quick pause and see if anybody has other auditing kind of related questions except for evaluation and management, because we're getting ready to go into E&M. But do you have any on anything else? The CPMA exam, you know, red flags, addendums to the medical record, anything like that?
I'm not seeing any in Facebook or YouTube.
I'm not seeing any in Facebook or the webinar, so I will go ahead and keep going. I just want to check. I don't want to keep going and nobody has asked their questions.
Lots of viewers, though, so
Awesome.
plenty of people are watching and listening.
Awesome. All right, so let's move into the evaluation and management questions. I've got 4 or 5 questions here that I want to make sure we go through. The first one is all about documentation levels, and the question says, back to E&M. In reality, how often will docs give us the HPI level, the H&P level, and the MDM level? My former coding instructor said, don't worry, it'll be given, but I really take this with a grain of salt. Well, I have a feeling that there may be a little miscommunication going on here. And I think the levels that this person was talking about were the history, the exam, and the medical decision-making levels. The 3 key components that we need to assign an evaluation and management service based on the location, right? Inpatient, outpatient, hospital observation versus inpatient admission, nursing home, all those different locations. And then usually some other factors, like if it's outpatient, we need to know if the patient's new or established. But then we really get into the nitty-gritty of the evaluation and management service, right? Those key components. And when we look at those key components, what your instructor in this case was probably talking about was for the certification exam. For the CPC certification exam, the questions do in fact give you the level of history, exam, and medical decision making, right? They'll say an expanded problem focused history, a detailed exam, and low-level medical decision-making. Like, they'll give you those pieces. However, real-world, day-to-day coding, and pretty much any other exam that you take at the AAPC other than kind of the CPC, right, that baseline credential, if you move into any of the specialty areas, especially the evaluation and management exam, if you move into an auditing exam, you move into those other areas, they're going to test you more extensively on evaluation and management services if that is a related part of that specialty. And if that's the case, they're not going to give you the level. They're not going to give you the level of history. They're not going to give you the level of exam. They're not going to give you the level of medical decision making. Instead, they're going to give you the different pieces to each of those key components and ask you to determine what the level is. So they'll give you the HPI elements. They'll give you the review of systems elements. They'll give you the past family social elements, and they'll say, okay, based on all this information, what's the overall level of history according to the 1995 or the 1997 evaluation and management guidelines? So that is something that's very different in the real world than it is from the CPC coding exam. All right. Moving on with evaluation and management, I've got another question that came in, and I like this question because it's one that I see people code incorrectly routinely. The question is about a new patient, and I am assuming when we're talking new patient, we're talking outpatient visit, problem-focused visit, those 99201 through 99205 codes. And in this case, there was no examination documented. So the question says, sometimes we see a new patient that does not want an exam. Do we have to bill this visit as an established patient since we only have 2 of the 3 elements? No. Okay, first of all, if you have a new patient, do not bill that as an established patient, because they're not an established patient. They're a new patient to your practice. So the next question that you got to think about is, did they truly not have any examination documented at all? Remember, vital signs qualify as a problem-focused exam area or a statement of general appearance. So the provider simply states no apparent distress, or their vital signs are documented and included in the record, we've hit that minimum level of exam that we need, and we can actually report a 99201 problem-focused exam new patient, assuming that we have the elements that we need in history and medical decision-making. But my next question would be more along the lines of, why was there no exam done? I get that it says patient doesn't want an exam. Well, I don't know about you, but I don't get to dictate to my physician a lot of the time what all they get to do, right? And a lot of the exam, they may not physically have to touch me. There's a lot of things that they can tell. They can tell my gait by watching me walk. They can tell my mood and my appearance by talking to me and looking at me. Those sorts of things can be documented. But my question would be more along the lines of, if there is not an exam documented, was this by chance an evaluation in which time was really the determining factor, right? It was mainly spent on counseling and coordination of care, the reviewing of test results, the prognosis, the risks and benefits of different management options, all of those normal conversations that our physicians have with our patients on a daily basis. I see this a lot in some surgical new patients, right? They know they're going to have surgery. They're a new patient to the physician. It's not a consult, because we're not asking for opinion. We're coming in for to establish care with this surgeon because they're going to be doing my surgery. And in that situation, oftentimes, it's more a counseling visit than it is anything. And if that's the case, the physician should be documenting the total time of the visit, the amount spent in counseling and coordination of care, or a statement that greater than 50% of the time was in counseling and coordination of care, and the content of that counseling and coordination of care. If it was not dominated by counseling and coordination of care, you are back to making sure that we hit the key components, history, exam, and medical decision-making. If that's the case and there is truly no exam documented, no, you should not default to an established patient visit, because to do so is to bill for a service that you did not provide. Patient's not established to your practice. Instead, as much as many of you are going to moan and groan and not like my answer here, you really should be reporting an unlisted service, because there is no code that accurately reports the service provided if that minimum level of a new patient visit was not met. And if that's the case, chances are, is the insurance carrier going to pay for it willingly? Probably not, because they're going to say, from a medical necessity, from a standard of care medicine perspective, you really didn't hit what you should have hit in providing that level of service. So something to keep in mind there. All right, it looks like we've got another couple questions coming in. Let's see. Anna, I'm going to answer your question first because it seems to dovetail right into this E&M question that we were just talking about. Anna says, what do we do if the past family and social history is missing in the emergency department with an unconscious patient? Of course you would ask me that question. The answer to that one is basically the physician has a little leeway in the situation of an emergent patient. Right? We're in the emergency room, and you've got an unconscious patient, and maybe you don't have any way of getting past family and social history because the patient's unconscious. Nobody came in with the patient. We don't have any additional information. In that situation, it really comes down to a couple of things. One, that the provider documents and clearly defines that, hey, I had no way of getting history. Right? Patient's unconscious, no other source of history available to me. Then typically what most of the carriers will do, and you can find policies on this if you go out and do a quick Google search, most of the carriers, what they will do is they will say, let the other two components, like the exam and the medical decision making, drive your level of code selection. And we'll kind of give you a little bit of a pass on that history component. Now you want to make sure and verify that with whatever carrier it is that you're reporting to, or if your carrier won't give you a rule, determine what you are going to do as a policy, right? Have it in your policies and procedures and follow that so that you can defend it if they come back to you and go, well, why did you do this? But it's very common, especially in unconscious patients, that the history component is kind of a buy, if you will. They give us a bit of a pass there because we can't get a lot of that unless we have another source of history, like we have access to previous medical records on that patient in our system. We have somebody that came in with them that can provide some history about what's going on in the patient's conditions. If we don't have that, there's not a lot we can do. Let's see. There's another question that came in from Diane. And Diane says, is the CPCO credential good to go for? I'm thinking of taking it. I'm a CPCO, so my initial gut reaction is, yeah, it's a great credential. The CPCO, for those of you who don't know, is the Certified Compliance Officer credential through the AAPC. I will say it is, from what I have been told, I have not taken the CHC through HCCA. I've been told that the CHC is more difficult, but tests on much of the same information as the CPCO. The CPCO credential tests you on just about every facet of compliance from a healthcare perspective that you can think of. If you were to look at the AAPC website, and I'll do that while I'm out here, show you what I'm talking about. If we go to the AAPC website and go under certification for the CPCO, this is another one of the exams that is completely multiple choice. It's 150 multiple choice questions. And as you scroll down to the bottom, they'll actually show you the areas, just like with everything else, the areas that the test includes. And if you click on each one of those, it'll tell you how many questions are on that section. The trick with the compliance certification, you are not allowed to take your coding manuals to the CPCO. And that's because they're not going to ask you to code. So they're like, why would we let you bring your coding manuals in? You're not going to be asked to code anything. It is very much from a regulatory and compliance perspective. They expect you to have a really good understanding of all of the different healthcare compliance regulation laws, from false claims and Stark and anti-kickback to the RICO statute and setting up a compliance plan for different groups, whether it be small group practices, third-party billing institutions, hospitals, those different pieces. So again, it's even different from the CPMA, right? It's one of the few exams that does not allow you to take in your coding manuals, but instead, if we look at what we're allowed to take there, we are allowed to take in, for the compliance certification, any published reference is allowed, except for the study guides or any reference published by HCCA. And this is one of the few that if you click on additional preparation methods, see if it'll come up here, they actually give you links on the, sorry, I have something in my eye, on the AAPC website to the different components. And this is broken down just as those areas are on the page we were looking at before to show the areas they're testing on. Like here they'll say there's 7 questions on healthcare compliance program history. Here are all of the links to some of the most common things you'll want to know about. Here's the history of healthcare compliance laws, federal sentencing guidance, the OIG 5-point strategy. If it's on this page, chances are you better know it, and you may want to print it and take it with you to the exam, because you really can come out here. Remember, any printed resource except those published by HCCA or the CPCO study guide that the AAPC publishes. Pretty much anything else is fair game. When I took that certification exam, I was a little bit overwhelmed in studying for it. It was before they had a, no, I take that back. They did have a study guide at that point in time, but I was still a little unsure of everything that was included, and they basically said, print out all of these different things and bring it in. Oh my goodness. I didn't even take everything that they told me I could have, and I had like a binder like this, just full of information. And quite frankly, I only referenced about 3 things. But I'd also been working as a compliance auditor for about 5 years by the time I sat for that exam. So I knew the compliance regulations pretty well, the penalties, that sort of thing. That's really what you need to know. And if you're going to take in a lot of materials like that, make sure that they are tabbed, make sure they're highlighted, make sure they're easy for you to flip through, because you are still taking a timed exam. and time is of the essence. So you really want to kind of work down to that. While we're at credentials, I see a lot of jobs available for a documentation specialist. Could you please briefly describe what that credential is about? So, documentation specialist, there are several different available credentials for a documentation specialist or a clinical documentation improvement. Anytime you see something about documentation, whether it be a documentation specialist, a documentation expert, a documentation improvement person, typically that role is there to provide feedback to the hospital, to the physicians, to improve documentation, right? Write more queries, help better adjust templates, and ensure that the provider understands all of the clinical pieces that need to be documented to best support the diagnosis that the patient has. Because some physicians, right, they'll tell you, we didn't go to med school to learn how to document and code. We went to med school to learn how to treat patients. So they need some assistance in their documentation. That's a lot of what that comes down to. The AAPC does have a medical documentation credential currently. This is the CDEO. If we go here, no, I don't want to know about their training, sorry. I want to see the exam. Okay, hold on. Let me switch. Let me go this way. Just kind of hitting a roadblock there. Here we go. The CDEO is the clinical documentation expert on the outpatient side of things. This credential very much focuses on outpatient documentation improvement, meaning physician and outpatient hospital side of things. AHIMA has a credential for documentation improvement, more geared towards the facility and the inpatient side of things. I don't know AAPC. I would speculate, because AAPC offers this outpatient credential, that an inpatient credential may be in the works a little further down the road. This is a fairly new one. This is one that just came out in the last year. And you'll notice under here, they kind of outline for you what the abilities that you need to be able to do are for this credential, and that kind of gives you an idea of what those individuals focus on in an employment role. So they've got expertise in reviewing medical documentation for accuracy, the ability to identify and communicate documentation deficiencies to providers, to improve documentation for accurate risk adjustment coding. So it takes into account risk adjustment as well as fee for service. A sound medical coding guidelines, regulations, including compliance and reimbursement. So understanding the different payment models, whether they be fee for service, whether they be risk adjustment, what those different impacts are and how the documentation affects our payment under each of those, as well as your typical anatomy, pathophysiology, medical terminology, and then the different coding areas. So it's a little different environment for many of us. This is something that started predominantly in the inpatient facility environment as a branch off of medical records and the coders at the hospital. And we're slowly seeing it evolve as we do many things, right? Medicare starts many of their processes and their audits and their focus in the hospital for bigger dollars, right? And then slowly it rolls out to the outpatient side of things in the provider offices. That's what we're seeing occur with this clinical documentation improvement and documentation experts and specialists and that sort of thing. All right. Just double checking. I see one more question, and I'm going to circle back to Julie's question after we finish a couple other things, because it's a little unrelated, but we'll capture it. Don't worry. I'm going to come back to that toward the end. All right, so we talked about E&M for a new patient. Let's move into E&M and history leveling. I put this here because it really kind of dovetailed off of that last question where the person mentioned that their coding instructor told them, oh, you'll be given the levels. Well, that's true for the exam. It's not true for real-life, day-to-day evaluation and management coding. So let's look at this question. It says, if you have to determine the level of history, you have to determine the history of present illness, the review of systems, and the past family social history. My question is, What if you come up with a level 2 in HPI, a level 4 in review of systems, and a level 1 in past family and social history? What would the history be? Now, the levels that are listed here are throwing me off a little bit, but I think I know what the person's meaning. And what I want to do is I want to take these numbers, so I'm going to jot them down real quick so I don't have to keep flipping between slides. So I've got HPI, I have a level 2. I'm assuming that's going to be an expanded problem-focused HPI. I have a review of systems of a level 4, which would be, well, it's either going to be detailed or comprehensive, depending on how we look at it. Let's call it a detailed. Say we're talking about code level. And for level 1 in past family and social history, that would be a problem-focused. But let's take a look at the audit tool. What I've done is I've taken an audit tool. I did not use the one that AAPC provides because it doesn't give us a very good summary box, and I wanted one that had a nice summary box. This is actually one provided by CMS. If you go out and Google CMS Audit Tool, it's one of the first ones that's going to pop up. And this is kind of the easiest way to determine where we're going to be in a level of history overall. So if we're looking at history of present illness, and we have multiple chronic conditions, right? We can capture HPI one of two ways. We can either capture it based on the status of 3 chronic problems or based on the individual elements. Now, with the status of chronic conditions, you'll notice, regardless of which way we choose, whether it's the chronic problems or the elements, there's really only 2 levels of HPI, right? Because these two, problem-focused and expanded problem-focused, are the same. So the lowest history you can get is expanded problem-focused, right? Either way. And detailed and comprehensive are the same. So really, you're either at an expanded problem-focused HPI or a comprehensive HPI. It's one or the other, right? You're going to get to one of those two for the HPI. So in this case, it says we had a level 2 HPI. So let's call that expanded problem focus. Let's say we had 2 elements. We had 2 elements of HPI documented, or the status of 2 chronic conditions. So we're here. Okay. And then for review of systems. Now this says a level 4 review of systems. We're going to pretend that they said 4 elements of review of systems, which is also going to take us to the equivalent of a level 4, right? So 4 elements of review of systems. When we look here, you don't have to have any review of systems for problem focused. You only have to have one body area, one organ system for expanded problem focused. 2 to 9 throws you into detail, and then you got to get all the way to 10 or more to get into comprehensive. So really, this one right here, this extended, right, this detailed level, is a very large catchment area. That's where most of your stuff is going to fall. In this case, if we had 4 elements, we would wind up over here. Right? So we only had expanded problem focus in our HPI, but we're all the way over to detailed in the review of systems. For the past family and social history, now this says we only have 1. Okay, well if I only have 1 area, I'm going to fall again here to the detailed, the pertinent piece, right? 'Cause I don't have to have any past family and social history for problem focused or expanded problem focused. But I have to have at least 1 to get up here to detailed. I have to have 2 or 3 to get up here to comprehensive. So in the scenario that this particular person gave me, and I'm going to draw a little circle so you know where I'm at, okay, we had an expanded problem-focused HPI, so I'm going to mark that. We had, duplicate that, we had a detailed review of systems, and we had a detailed past family and social history. How do we determine then our overall level of history? Well, it says right down here that all criteria for a given level must be met or exceeded. So, did we meet the criteria for comprehensive? Nope, we didn't get there in any of our areas. Well, what about detailed? We got to detailed for past family and social history. We got to detailed for review of systems. Did we get there for HPI? The answer is no. So we have to step down 1 more. So we didn't hit detailed, we didn't hit comprehensive. When we look at expanded problem focus, did we meet or exceed all of these areas? Did we meet or exceed past family and social history? Yep, we exceeded it. We got more than we needed. Same thing with review of systems. For HPI, we met it. We didn't exceed it, but we met it. So we would be limited right here to an expanded problem-focused history. That's really how you determine it. Your lowest level of any one of those three is going to determine your overall level of history. So it doesn't matter how it maps out. Maybe you got, right, expanded problem-focused, detailed, comprehensive. Your lowest one is going to drive your selection. Maybe you had no review of systems and a comprehensive past family and social history. In that case, if this is what mine looked like, where am I going to be? Go to the lowest one. I'm stuck with a problem-focused history. Okay? Same thing. And remember that with the HPI, I only have one or two options, right? I either have expanded problem-focused or I have comprehensive. Really, there's just those two. If my history looks like this, what's my overall level? You drop to the lowest, right? Down here for problem-focused. All right, I'm going to check questions real quick. All right, let's see. We've got one that says, Christina says, would you say this is a little advanced for the exam? Depends on which exam you're talking about, Christina. If we're talking about the CPC, absolutely. But remember tonight, we're all about auditing and practice management. If we're talking about the auditing exam or the evaluation and management exam or many of the specialty exams, this level of understanding for evaluation and management is what you're going to have. For just the CPC exam, don't fret, because they're going to give you your level of history, your level of exam, and your level of medical decision making. So don't let that throw you off too far. All right, Anna had another question. She said, so if the patient is unconscious, do you just skip that? I mean the past family and social history level. Yes, Anna, when we were talking earlier about that emergency department encounter, and that if a patient is unconscious and the provider has documented that they're unconscious and there's no other source of history, yes, you can skip that piece and you use your exam and your medical decision making to really drive your level of code selection. And again, refer to your carrier rule to make sure that that's what the carrier allows, but that's what most of them do. They say base it on your exam and your medical decision making, and we'll kind of give you a pass on the history because the patient's unconscious and can't provide any of that information to you. Yep, you're good. All right, let's see. Just want to make sure I haven't missed anything other than the one that I got to circle back to here in a minute. Okay, the next evaluation and management question comes down to medical decision making and conditions not treated. Question came in and says, evaluation and management question on medical decision making. If the provider is not treating a problem, and I think that's supposed to say does he or she still get credit in the table of risk and diagnosis points? For example, if a patient comes in for a follow-up of a diabetic foot ulcer, patient also has peripheral vascular disease and neuropathy. The provider only treats the ulcer. The HPI is detailed, the exam is expanded problem focused, the assessment lists diabetic foot ulcer only. I would code diabetes, foot ulcer, peripheral vascular disease, and neuropathy. Would the medical decision making be moderate because there's 2 or more chronic conditions, or low because only the diabetes and the foot ulcer are listed? No medications are given and only treatment is directed at the dressing changes. This is a question that we find actually pops up rather frequently when we're looking at coding for evaluation and management services. If the assessment only lists the diabetic foot ulcer, from a coding perspective, that's what we should be reporting. My question to the person that asked this question is the peripheral vascular disease and the neuropathy documented elsewhere in the note beyond just the past medical history? If they're only documented in the past medical history, that's not something I'm going to be picking up unless I'm coding for certain risk adjustment plans that may direct me to do so. But in a day-to-day coding environment, remember, I'm not going to be coding from the past medical history. I'm going to be coding based on the history of the exam, the medical decision-making, and what it is they said was not only directly treated that day, but what things impacted the care. The diabetes and the foot ulcer, those are going to be two problems, right? So we are going to still have both of those that are going to factor into the number of management options as well as the risk. The peripheral vascular disease and the neuropathy, I would not count those if they're only in the past history, right? In that problem list or the past medical history. Now, if the provider addresses them in any way or indicates in either the plan or the assessment that is factoring into how they are treating that patient, and they're going to, right? Peripheral vascular disease is absolutely going to factor in how we treat a foot ulcer on a diabetic patient. So what I would really do is I would wind up querying this physician or going back to the physician and asking, you know, I noticed in the past medical history this patient has peripheral vascular disease and neuropathy. Did that impact your medical decision making that day? Did you think about, because remember, medical decision making is an abstract way for us to quantify and qualify the thinking that a provider is doing. It's really just three different ways of looking at the amount of thinking and brain work that a physician has to do, right? Because first we're looking at how many different conditions did they have to treat, what was the nature of each, was it a new problem or an established problem, was it stable, was it worsening, did we have to get additional information on it? Then we look at, okay, what additional information did we need? Did we have to talk to another provider? Do we have to order a lab test? Do we have to review an x-ray? Those types of things. And then we look at the risk to the patient based on the presenting problem, the diagnostic test, and any management options selected. And according to the the E&M guidelines, when we look at the 95 and 97 guidelines, they actually say the number of possible diagnoses and or the number of management options that must be considered is based on the number and types of problems addressed during the encounter, the complexity of establishing a diagnosis, and the management decisions that are made by the physician. And that's when they start taking into consideration that, you know, they give you more credit for a new problem than an already established problem. They give you more credit from a thinking perspective for something that's getting worse than something that's staying stable or improving. So basically what we need to know is, did these other conditions, were they addressed? Were they impacting the complexity of establishing the diagnosis for that day? Or did it affect the management options that the physician made? Chances are, for peripheral vascular disease and neuropathy in a patient with a diabetic foot ulcer, yeah, it's going to affect the management decisions. The provider probably did not include them in their assessment because they didn't understand the impact that that was going to have on their coding and their code selection. So can you count it? Can you code for it? Kind of depends on where it is, but absolutely, I would say it's going to be pertinent, and I would have queried that physician to ensure that it really impacted their care that day, and if so, ask them to add it to the assessment and plan. They really should be documenting who's managing those other conditions and the impact those conditions have on that diabetic foot ulcer. Okay, I've got another question related to E&M that just popped up real quick. With medical decision making, the word workup is defined differently by AAPC for the CPC and the CEDC credentials. Could you please define what workup really means? For the CPC, it was lab orders, x-rays, whatever is needed to establish a diagnosis. But for the CEDC, it's anything provided after, anything the provider orders after the diagnosis is established. Well, we're always consistent, aren't we? We're consistent in our inconsistency. What does workup truly mean? And it's not just AAPC that interprets this differently. Many of the carriers interpret it differently as well. The definition of workup. Let's go back to, first of all, let's think about, many of these terms are created in describing what a physician is doing. When a physician goes to med school and they're doing rounding as a resident, that sort of thing, they are taught to quote-unquote work up a patient. And what does working up a patient involve? Well, a basic workup is a history and an exam, right? They go in, they get a history, and they examine a patient. They have worked up the patient, and they then present that information to their attending or to whoever it is that they're rounding with to get feedback on that. So above and beyond that, right, additional workup would then be those elements above and beyond that needed to establish the diagnosis, including lab results, x-rays, any kind of additional testing out of the medicine section, those sorts of things. That's my interpretation of it. However, as we know from the question that was asked here, both the AAPC and many other carriers define that differently. Some of the carriers say additional workup counts as additional workup planned as long as it's not something you did the same day. What does it matter when day I did it, right? What does it matter if I do a venipuncture later today or if I wait and have the patient come in tomorrow? I still need additional information. But from a carrier perspective, many of them say, oh, no, workup as done on a following day. Regardless of when the diagnosis is established, it can't be the same date of service as the evaluation and management service. When you really get into E&M and coding for E&M, quite frankly, what I'm going to tell you is you need to be familiar with your carrier rules and how they interpret all of those different ramifications, because it will very much impact your level of code selection. What many organizations do is they look at what all of the different payer policies are, and they go with the most strict, because then they only have to really memorize one, and it makes sure that they adhere for everybody else. But it can mean that you're leaving dollars on the table in some other situations. So you really want to be familiar with those levels. But a true workup, right, an initial workup that a physician is taught to do in med school is a history and exam. So additional workup would be anything above and beyond that, those additional tests, lab works, x-rays, EKGs, all of those. But again, it very much varies based on your payer and your carrier. Okay, on to our last question for evaluation and management. This is a biggie. This one is around chief complaint documentation requirements. And let's just take a look at this one. It says, question, is there a specific requirement anywhere that says the chief complaint must be documented in the beginning of the progress note or history portion of the note? I have found very contradicting information. A provider is wanting to know if it would be acceptable to just write CC, chief complaint, and 1, CHF, in the assessment portion of the progress note. It's not something I've ever seen, but I'm unable to find anything that would prevent him from doing this. The answer that I've provided so far, this is not my answer, this is the person that asked the question, says, great question. And a chief complaint is something that is the reason the patient is there being seen, so it should be in the beginning or the meat of the progress note. Both the 1995 and 1997 documentation guidelines for evaluation and management services advise it can be listed as a separate element of history or included in the HPI. Here's the actual verbiage found in the documentation guidelines. I actually went on to cite the same thing. Okay, so the first thing I do when somebody asks me an evaluation and management question is pull out those 1995 and 1997 evaluation and management guidelines. When we look at those, both the 95 and the 97, the history elements are the same, with the exception of the status of 3 chronic conditions for HPI, but we're not going to get into that. We're focused on chief complaint right now. And the chief complaint is defined as a concise statement describing the symptom, the problem, the condition, the diagnosis, the physician recommended return, or the other factor that is the reason for the encounter. Sometimes called the reason for encounter, this is physician work. Should be documented by the physician. Typically, it's included as part of the HPI. They may not, there is no requirement that says it has to be distinctly called out as a chief complaint. Right? It does say the medical record should clearly reflect the chief complaint. That does not explicitly say it has to be documented as the chief complaint. And in much of what I have read from Medicare and other payer interpretations, it has to be easily inferred. from the documentation, right? I have to be able to read the documentation and understand why the patient came in. That qualifies as my chief complaint. It is considered one of the areas of history. Therefore, it really should be documented or at least inferable from the history elements. I would not encourage a provider to put his chief complaint in the assessment. The assessment has nothing to do with the HPI, right? Well, it does, but it doesn't. The assessment is very much part of the medical decision making. That's usually what is driving our medical decision making. Can the chief complaint be documented there? There's nothing in the rules, quote unquote rules, in the guidelines anywhere that says anything has to be documented explicitly in a specific place. Think about a SOAP note. In a SOAP note, do we call it HPI? Do we call it review? No, right? We call it subjective, and it's the entire history. It's the HPI, it's the review of systems, past, family, social history, chief complaint, all in one. So there's nothing that explicitly says it has to be labeled or appear in a specific part of a note. And we do review every encounter as a whole. So if I'm looking at a physician record and I'm looking at a specific data service, I'm looking at that data service's note by that physician as a whole. Could I use the assessment? Well, that really depends on your carrier and your personal interpretation. In my opinion, no, because the assessment may reflect a disorder that is not the same thing as why the patient came in. And that chief complaint, or at least the subjective portion of the note where the history is documented, I should be able to read and easily infer why the patient came in. Right? Follow up on hypertension medications. Okay. Maybe they're here for congestive heart failure. Follow up on chronic conditions. Okay, what are those chronic conditions? The assessment is used to clearly identify what the diagnoses are that we're dealing with, and usually then parlay into the plan to say what we're going to do with each of those different pieces. So is there anything that says that they have to document it at the top of the note and call it a chief complaint? Heck no. Should they be documenting it in the history? Absolutely. There should be a subjective or history portion of that note where I can clearly identify why the patient is coming in, above and beyond whatever the assessment says. Because that really should be giving me, remember the HPI is the history of the present illness. It's painting a picture of the problem for which the patient came in, right? How long has it been going on? How bad is it? What kind of medicines have they tried? What worked? What didn't work? What additional signs and symptoms do they have? All of those pieces should be there, and I should be able to easily infer that. If I cannot infer a chief complaint, do I have a billable service? The answer is no. Now, some carriers have gone as far as saying, if the only place we can figure out why the patient came in is the assessment, you don't have a billable service. Most of them are not that stringent. Most of them will say, all right, if I can tell from the assessment why they were here, I'll give you that. But there is a lot of contradictory information out there. All we can really do is tell you best practice and what to work with your physicians on. Best practice is to explain to the physician. If you're a physician and you're looking at another physician's documentation, don't you want to be able to tell why they're here? Right up front, shouldn't it say, oh, they're here for a follow-up of their hypertension. They need to refill on their medications for their hyperlipidemia, whatever it may be, and have some of the pertinent information around what are their blood pressures running, what other signs and symptoms are they having, how long has this been going on, that sort of information. It works the same way. The medical record is intended to paint that story and allow not only for defensible documentation for billing, but it's also there so that we have a clear continuity of care and show what was done during that encounter and what items were addressed. So we want to make sure that we have all of that information. All right, now we're ready to jump out of the world of evaluation and into our practice management questions. I only have a couple of practice management questions, so hang with me. We're wrapping into that last half hour, right? Practice management. First question that I kind of have here is, who does the coding? This question says, do all physician offices have coders? I asked because I spoke to the medical biller at my physician's office, and she told me that she does not code, nor is there a coder in the office. She just bills the code the doctor has plugged into maybe a coded note or some other system. Is there any truth to what she said? Well, yes, there is. I don't really think that that biller was trying to lie to you. I really don't. The answer is yeah, there's absolutely truth to this. Most physician offices, I won't say most, I will say not all physician offices employ a coder, period. Some physician offices do employ coders. Some outsource their coding services to a third party. Some organizations and practices, the physicians are responsible for their own coding. They actually have to code their own services, and there's just somebody on the back end that works denials. I know that's true of one of the largest hospital systems I've worked with. Their physicians were responsible for doing their coding assignment. And in some groups, they would hire a coder to work for, but they had to come out of their department budget for a coder. And not all physicians see the value of a coder. I will tell you that a good coder is like a good coupon. It'll save you a bundle, right? It'll help improve your bottom line. But not all physicians see that. It is not unusual to come across a physician office who does not have a coder. So no, it's not that they're lying to you. It's that the practice that they have, either the physician does their own coding, they outsource the coding, and more than likely, especially if they're a small practice and they're a small physician-owned practice, not owned by a hospital or an entity group, they probably don't have a coder because the provider really probably doesn't understand the value add of a coder because of the additional money that it would require to hire one. However, more and more of those small group practices are being purchased up by large healthcare groups. Hospitals are buying physician practices right, left, and center. And even in some of those, I mean, I work with a very large hospital system in the state that I live in, and the vast majority of their physicians are responsible for their own code assignment. They're trained in coding. They have to go to classes on evaluation and management selection, and they are audited based on codes that they select. Now again, some of them they pool their resources as a department and hire a coder because they don't want to worry about all of that. But again, that comes out of their department and their bottom line. So it really depends on the organization that you're working with. But yes, it is true that there are some offices out there that do not have coders. All right, the next practice management question, and the last practice management question I have pre-prepared, is about combating Medicare reimbursement decrease. This was actually a question that came in from a physician, and it says, I received a letter from CMS stating that my Medicare reimbursement would be decreased by 2% in 2017 because I did not meet the reporting criteria for 2015. I have a letter dated April 25th of 2016 that says I was approved and granted a hardship for 2015 and will not be subject to the payment adjustment for 2017. Please let me know what I need to do to correct the issue of decreasing my Medicare reimbursement for 2017. This happens more often than you would think, unfortunately. And what needs to be done is you actually need to appeal to your Medicare administrative contractor. You really need to reach out to your provider rep with your MAC and provide proof of the hardship that you were given and have them adjust your rate accordingly based on the information they've already given you. It sounds like they simply didn't pay attention to what they had on file in their records. So I've given you a list here of all of the Medicare administrative contractors by state or jurisdiction. This is last updated July of 2016. It's the most current one I could find on the CMS website. And it's not difficult to find the addresses for these. I mean, you can just go out and Google Meridian or CGS or whatever it may be to get the address that you need to reach out to or the phone number that you can call. And this shows you, which states are included in each jurisdiction, so you can figure out based on your state which one you're looking for. But that's really what needs to be done. You have to reach out to your Medicare administrative contractor and let them know, hey, there's an issue here, to get your fee schedule adjusted. And chances are, since we are now almost in February of 2017, they will have to adjust your rate for January of 2017, which is going to put a little bit of additional work on whoever's posting your payments and adjusting things. But you'll want to make sure that that's captured so you ensure that you got the correct payment for the services you provided in January. All right, let's see what other questions I have before we move to the wrap-up. There was one more question that I skipped over. And this was a question from Julie Johnson, and Julie says, what can you write in your ICD-10 book and other materials for the CRC exam? When we start talking about writing in our books for certification exams, there used to be an old note out there for proctors that said that books could not be disqualified due to handwriting contained therein. That's typically the rule that most proctors follow, but it's no longer one that's expressly listed in the instructions that we receive from AAPC, unless they changed in the last 2 weeks, which sometimes they do. They change pretty frequently. But basically what it says is you can make any note that is useful to you in a day-to-day working environment. So you can have several notes. You can have notes about the guidelines and how they apply. You can have notes in your book, like I recommend, for example, in ICD-10-CM, in the E13 codes, right? E13 is other diabetes. I have a note there where they talk about post-procedural diabetes mellitus, or post-pancreatectomy diabetes mellitus. I have a little note there that there's a guideline that says if I use that code, if I use an E13 code for post-pancreatectomy diabetes, I really need to code first post-procedural hypoinsulinemia, which is an E89.1, because that's one area that it seems to actually be missing a code first note in the tabular section, and doesn't direct me to that. So you can make little notes like that that help you ensure that you get the right code order. I've seen some individuals go so far as to look at the CMS HCC listing and either highlight or circle all 10,000 codes that risk adjust, just so that they know they want to make sure that they're picking up those codes for specific encounters that they ask you to code during that risk adjustment certification exam. That's completely acceptable, because from a day-to-day work environment, that's an easy way for me to tell if that's a code that I need to capture or not, if I'm only doing HCC code assignment. So when it comes to the things you can write in your books and your materials, that sort of thing, that's what you can do. What you cannot do, you cannot be writing in sample test questions from practice exams, things like that. They have to be notes that are relevant to what you would be doing in a day-to-day basis, coding for those. Things to give you hints to help you remember, oh, I might need a modifier 26 on this code, or I might need, those types of things. You want to be cautious of how much you write in your books. Notes are helpful, but you don't want to write entire paragraphs of information in your books, because you're going to run out of time trying to skim it all to figure out what's important. If it's something you truly don't know, work to learn it rather than make a bunch of notes in your book that isn't going to help you. That's going to bog you down in trying to skim through it and read through everything. All right, are there any questions that I'm missing? Any questions anybody wants to add?
Seems like everyone's satisfied.
All right.
Oh, we got one last minute one there. It's okay, Anna.
Anna, you're allowed to ask questions. It's not a problem. Has AAPC incorporated the CC changes into their exams? When you're talking CC there, are you talking about the complication and the complications and comorbidities, the CC codes? Oh, yes. Okay, I know what you're talking about now. Sorry, it took me a minute. I think what you're talking about, because you asked about diabetes coding and the advice on gastroparesis, some of the changes that occurred with the 2017 guideline changes for ICD. I have a feeling that's what you're talking about. Am I correct? The interpretation on width and those types of things. Yep. Okay, so I wanted to make sure I'm on the same page here. When we look at the AAPC exams for 2017, remember that those have been revised, and they have been revised to reflect the guideline changes for 2017. There were some pretty significant changes in the guidelines for 2017 for ICD-10-CM. The one that in particular was a drastic drastic change from the way things were done before is the interpretation of the phrase or the word with, right? In the past, in 2016 and prior, if a provider documented that a patient had two different conditions, let's say they had hypertension and heart disease, if they did not explicitly link those two conditions in their documentation by either calling it hypertensive heart disease or heart disease due to hypertension, we could not code the conditions as related. The only condition that we were able to do that for before 2017 was hypertension and CKD. That was the only thing we were able to kind of say those two are related. In 2017, the World Health Organization, the Centers for Disease Control and Prevention, did make a change to the interpretation of the word with in the ICD-10-CM manual and in the guidelines. And basically what that guideline now says is that if any two terms are linked in the alphabetic index or in the tabular list by the word with, they are considered to be related, associated, or due to. So now, if we have a patient who has diabetes and a complication, right? Maybe they have diabetes and neuropathy. Because those two terms are tied in the alphabetic index, right? Diabetes with nephropathy, we now automatically code them as related. It's a complete reversal on opinion of how we've coded these for years. And that is a significant change. Yes, AAPC has made that update for 2017, is my understanding. That those changes have been made to the certification exams for 2017, taking into account the new and updated guidelines. So yes, you will want to know what terms have that with documented, right? And when basically what you're going to want to do is check the alphabetic index to see, do I have diabetes with these as an option? Because if so, I need to code them as related conditions. And that makes a significant impact on how the different diagnoses are reported and coded. All right, cool. That being said, I think we are ready to wrap up now and do our recap. We covered a lot of information tonight. We went through a lot of different information. We started out with our auditing and compliance topics, and we focused mainly on addendums to the medical record, making the jump from the CPC to the CPMA, the auditing credential, and we even talked a little about the compliance credential in there. We talked about whether or not multiple low-level visits by the same provider in a month would trigger a red flag or not to certain payers, specifically Medicare. We went into evaluation and management coding, and we talked about documentation levels and new patients with no exam and how to determine the level of history and what to do if medical decision-making conditions were not treated. Can we count those? Can we not? Chief complaint documentation requirements. History requirement documentation for patients who were unconscious. And we also went then into practice management. We talked about, do physicians really do their own coding in some situations? Is there really not a coder included in the practice? And what do we do if Medicare is not honoring what they told us they were going to do for reimbursement purposes? Where do we start to fight that battle and get that corrected? We've gone through a lot of information tonight. We really appreciate the topic requests that you've given us and the questions that you have. Don't forget, if you have a topic you would like to see presented on a future call, whether it be a student support call, whether it be one of the Did You Know events, one of the Live with Lorene's, one of the Q&A webinars, all of the different types of venues that we do, please, please, please feel free to fill out a topic request form. I'll show you real quick where you can find that. If you go out to our website at cco.us, right up here at the top, if you hover over, go here. If you hover over Contact CCO, it's the fourth item down, says Topic Request. And you'll see here we give you a description of all the different venues that we have, and you can put in exactly what it is you'd like to see us present on. And you can even tell us what venue you would like to see it included on. Please make sure if you're filling this out that you really do give us a detailed request or description of what your request is, what information you want to see us cover, because without that information we have a really hard time putting together a topic that really addresses the question that you had. So please provide that specific information when you can. That being said, I think we have answered all of the questions and we have done all of the things. And we look forward to seeing you back again soon. I know we've got a Did You Know coming up tomorrow and a Live with Lorene on Thursday and another student support call next Tuesday. So please dial in and see us again then. And in the meantime, happy learning, and we look forward to seeing you again.